Hi, I'm Claire Walters. I'm one of the sonographers in Rocky, and I'm just going to do a presentation this evening on lung ultrasound. So aims of this presentation are to refresh and update knowledge on lung ultrasound, including the relevance and importance of it, the equipment and the scan technique we use, how to recognize normal features and pathologies. So relevance and importance of lung ultrasound. I've noticed an increase in requests for chest ultrasounds at the base hospital here in Rocky, probably because of the amount of influenza that's going around. They're often from ICU and ED, and the patients are particularly unwell sometimes. Pediatric patients can be quite unstable, and the scan is often used to guide decisions in transferring those children to Queensland Children's Hospital in Brisbane. Those with empyema are generally transferred away from Rocky, so it's quite important that we get that right. Diagnostic scans are often requested for the assessment of guided drainages, which then we do in the department, obviously. Ultrasound is very good at diagnosing lung abnormalities, and it's fast, low cost, portable. So we'll just have a look at some of the equipment. We've got the main curvilinear probe that we use for a lot of scanning at depth, which is a useful place to start. We've got some high-res curvilinear probes here and also a linear probe. You can use a sector probe. We don't have one at Rocky Base. If it's available to you, it's also an option. The aim should be to use two probes, one for a global view and then one a more detailed view. The preset selection can be renal, bowel, abdominal. Some machines have chest, but ours don't. You do manually want to disable filters and harmonics because lung ultrasound is based on visualizing artifacts a lot of the time, so those need to be turned off. Patient positioning for the scan. Ideally, the patient is seated on a bed with their back towards you. A supine patient who's not well enough to sit up can still be scanned. If you can get them into a slightly recumbent lateral decubitus position, or at least just lift the arm up, that's helpful. So the probe positions, the chest is divided into 6 zones. An anterior, a lateral, and a posterior zone with upper and lower zones, labeled 1 through 6 there on those pictures. So the normal lung appearances and artifacts. The interaction of the sound beam with the air in the lung leads to artifacts in the normal appearance of lung on ultrasound. There's predominantly the visualization of artifacts caused by reflection and reverberation. So this first image here showing A lines, which is the reverberation artifact, and shows horizontal reflections which decrease in intensity with depth. And you can see the rib shadows there. And then the second image showing the B lines, which are vertical laser beam artifacts. Less than 3 of those is seen in normal lung, aerated lung tissue. And then lastly, you've got C line, which is just the pleural line. So normal lung sliding is seen here with both a curve probe and a linear probe, sometimes described as marching ants. It's a glistening movement at the pleural line because of the interaction of the air with the sound beam. Pleural effusion query drain, it's a very common request in an ultrasound department, particularly in a hospital. Ultrasound's great at visualizing the fluid and differentiating the simple from the complex effusion. When the lung is collapsed or consolidated, the A lines are obliterated because there's no air there, and this allows us to see the lung tissue quite clearly with the fluid surrounding it. Simple effusions are obviously anechoic, with the collapsed lung seams of flapping around in there. Complex pleural effusions show more heteroloculated fluid collections with thickened pleura. These two images just are an example of a simple and a complex fluid collection. So tips and tricks for scanning lungs. Ask the patient or the clinicians, particularly if you're doing a mobile scan, they're often quite forthcoming with information about suspected infections or results from pathology or any other causes that might be suspected that are not infective. Have a look at your previous imaging. They've often had a chest x-ray. We all start scanning with a curvy and have a look at the depth and the extent of the effusion. While I was going through images for my presentation from the last few months, I noticed that the linear probe wasn't used. So the curvy is good for an overview of depth, but consider extending your study by using a linear probe or a higher res curve probe. And then remember your knobology, depth focus, TGC, and increase that overall gain to see some of those echoes in complex effusions. So in saying that, just looking back at these pictures here, is this really a simple effusion? So this is actually the same patient on the same day, looking through the same window. However, this image has been optimized better in terms of a slightly high overall gain, slightly lower depth, you can see there. And so consider extending your study with a linear evaluation. You can see these pleural lines much better. They're quite thickened in that picture. You can see the echoes and the heterotexture of that thick pleural effusion or empyema. And then you can add that color shows that vascularity in the thickened pleura quite well. And you can have a look dynamically. This is with that patient breathing. There's very little movement of that lung in the presence of that complex effusion. And then going on to consider visualization of infection and what it looks like. So you get a loss of the A lines. You don't see any of that reverberation in any of these images. You get an increase in the B lines. You can see them here. Collapsed lung with that fishtail sign. So you can see that collapsed lung there. If this was a video clip, you might see it flapping around. Consolidation, which includes air bronchograms, which you can just see in this image down here, but I've got another slide with a bit more imaging of consolidation. It becomes liver-like, which is what this is showing. This is actually the spleen, but this tissue looks very much like organ tissue when the image rolls around like that. In this particular image, you can also see movement of those air bronchograms. So just there's sort of breathing, and you actually see them moving. The outcomes with dynamic air bronchograms is actually better for the patient. So thickened pleura with vascularity we saw before, and these sort of hypoechoic areas can be necrosis within the lung tissue. So the air bronchograms that we mentioned before, and the shred sign is seen here. Consolidation shows these little air bronchograms in this dynamic image, and in this still image you can see them. That's air in the bronchioles, and you get this shred sign here with the consolidation in the lung. You can differentiate viral from bacterial to some extent. Viral tends to have smaller scattered consolidation with no pleural effusion, whereas bacterial tends to have a larger pleural effusion and empyema. So just to look at some non-infective pathology, which I'm only going to mention briefly, you can get pulmonary edema, which tends to be bilateral because it's a systemic condition. You have the loss of the A lines and lots of B lines. And the pleura is normally thin. Pneumothorax, you get obliteration of the sliding sign. You see the A lines, which you can see in this image here, but you really need to find a lung point for confirmation. And a lung point is actually this point at which you have the normal sliding lung meeting that air within the pleura that doesn't slide, to differentiate or confirm it to be a pneumothorax. This is an interesting bit of research done in France by some ICU doctors on lung ultrasound. Makes for good extension if you want a bit more info on things, a bit more depth. Quite successfully differentiating a number of lung pathologies. There's a simplified version in the image below and quite a good worksheet. And then some takeaway points. Add a linear probe to your protocol and increase your 2D gain to confidently differentiate simple versus complex effusions. These are just my references. Thank you for listening to my presentation this evening. I hope it was informative.